Good evening, everybody. Welcome to our April Conversations on Brain Health. I'm looking forward to have a good conversation with some of our very own Rush MS specialists who are going to be providing us with some updates on some research projects that are going on. And we'll be ending today with having Ren Dalfors from the National MS Society giving us an update on the Walk MS event that is going to be happening here at the end of the month on April 27th, as well as Bike MS. So on that note, I know we are right on time here and we have a lot of information to share. So I'm going to turn this over to Dr. Augusto Miravalle, and we will highlight all of our MS specialists who are going to be speaking this evening. So Dr.
Excellent. Thank you, Kathy.
I'm going to turn it over to you.
Oh, perfect. Yeah, you just froze for a minute, but thank you, Kathy. It's great being here again. Welcome to our April Conversations on Brain Health. And as usual, as Kathy mentioned, we are trying to give you, our wonderful audience, a meaningful conversations on things related to brain health. And today we have selected a topic that has to do with what is new in the field of multiple sclerosis, what is happening in research, what was shared in recent international and national meetings that perhaps may relate to advancing the care of, and our understanding too, of multiple sclerosis. So with that, I thought to start with something local, something that is happening here in Chicago at Rush. And we have exciting news to share with you that is coming from Dr. Tyler Kaplan and Jules Skoda, two of our members in the team. So I'm going to pass this on to Dr. Kaplan. So if you can tell us more about your research and your protocol and how can patients participate if they're interested.
Yeah, absolutely. Thank you, Dr. Miravalle. Yes, hello, everybody. For those of you who may not know who I am, my name is Dr. Tyler Kaplan. I'm one of the attending physicians here at the Rush MS Center, and very happy to be able to talk to you today about a new project that we are getting up and running here in the very near future through a very generous grant we've received through a charitable foundation. We are starting a new pilot project this year that we are calling the CLIP MS study. And that's an acronym for a comprehensive lifestyle intervention for a program for multiple sclerosis. And so that is essentially what it's going to be doing, is synthesizing the current offerings that we already have available through the Brain Health program, but essentially kind of adding some structure and a kind of a reproducible protocol to it. And so this first year, we have funding to enroll 20 total patients. So it's going to be a small project for the first year. And then, of course, the hope is that we can then use that, the data and the research we get from that project to expand the program and make it a much wider offering for lots of the patients here at the Rush MS Center. So it's going to be a combination of the 3-week educational brain health program that Dr. Miravalle and Kathy currently are running. So that's those quarterly meetings, the 3-week programs. So for those of you in the audience who may have already been enrolled in those studies are familiar with kind of the standard of that. And then after that, it'll be a 1-year program working with our nurse practitioner, Adrienne Castillo, in the Brain Health Clinic. And that is something that I'm sure several people here have already had an opportunity to work with Adrienne as well. And so basically our primary objective is to take a small group of people and, number one, just see how feasible this is as a broader project. So we're going to be studying, how well, how convenient it is for patients, what their experience is with it. Is it something that they can work into their daily lives? And then at the same time, we're also going to be monitoring patients' quality of life metrics. So we're going to be asking lots of questions and getting lots of information about lots of different aspects of living with multiple sclerosis and how and how that evolves over time. And like we said, as this is a pilot project, the goal is then to get meaningful data that we can then use to get greater funding to really expand this to a much larger product. So for those of you who may be interested, we do have a few criteria as far as kind of the patients that are going to qualify for this study. The main thing is it's somebody who is 18 or older, who is a established patient here at the Rush MS Center, has a diagnosis of multiple sclerosis, and then that essentially patients that have not already gone through the existing brain health programs, like either the 3-week program or are already established with Adrian in the brain health clinic. So for anybody who hasn't already gotten involved in those projects and have been interested in maybe getting involved, this is a great opportunity to just get involved with some of these great programs that we have available for patients, and then also be able to contribute to research for just improving quality of life for MS patients in general. So for anybody who may be interested, they can contact Jules. Jules Skoda is our clinical coordinator here, and she's going to be kind of the quarterback on this project. So Jules, maybe you could put your contact information out there in the chat for patients, or then Jules, I guess if you have any additional words that you would like to say about the project.
I think you really hit most of it, but it should be, like Dr. Kaplan said, taking off shortly. We're just kind of waiting on a couple of pieces, but we will have flyers around the clinic too, so you can keep an eye out for those. And I will put my email address in the chat so you guys can reach out to me if you're interested.
Excellent. This is very exciting. So basically, if I understand correctly, this is looking into services that are currently being offered at Rush. So even if patients perhaps don't qualify, they can still get the benefits of these services. But what the research is doing is trying to understand the impact of those programs, but most importantly, the feasibility, right? So being able to say, well, are these interventions truly making a difference? And are these interventions being able to be followed by patients? And is this something that is actually making the impact that we are hoping? Is that correct?
Absolutely. Yeah, and that's a very good point. Yeah, even if somebody does not necessarily meet all the qualifications for this specific study, these individual interventions and programs are still available for all of our patients. So they can still individually access those resources, even if they're not specifically part of this study. Yeah, and our general idea is, taking these multiple kind of different programs that individually, haven't necessarily been rigorously studied on their actual impact on patients, and kind of combining them together, and if the idea of having kind of this reproducible model, this intervention that then we can say, okay, we have this data that shows that people who do this specific protocol to have this much benefit, and we can use that to implement further opportunities and get the funding to make this a much broader project available to most, if not all, of our patients.
Excellent. And, I take this opportunity to remind the audience to participate by writing your questions in the Q&A chat. Kathy is going to be monitoring that throughout the session today, so feel free to ask any questions you may have. When you reflect about lifestyle interventions, I think we all know the benefits of that, and research continues to show and support the fact that things like exercise and diet, and even things like mindfulness, meditation, stress reduction, sleep makes a huge difference in our life with or without MS. But perhaps the big challenge become not necessarily understanding the what, right? So what are the things that we need to do better, but it's perhaps the how, right? So how can we implement these changes in our life in a way that is meaningful? And that's the difficult part of things. So I'm glad that you're spending time. I'm glad you're spending effort in trying to understand the how, which is perhaps the most important question. Anything else that you want to share with us?
I think just the other thing we do want to point out is, for this pilot project, for the patients who are enrolled, it is free to patients. So they will not have to pay anything for any of the programs. So at least for this first year, it will be fully funded through the grant. So, and their patients who are involved will receive a gift card for a small amount of money, just as a token of our appreciation for being involved with all the data collection and all the checkups and everything.
Excellent. And do they have to be Rush patients, or can anyone participate?
So right now they would need to be established at
Okay.
Rush. I mean, because part of that would be being so that they could be enrolled in the medical records, so we can access the data, as well as being able to actually obviously go to the appointments with Adrian
Okay.
as research appointments.
Very good. Well, this is exciting. And are we ready to go? So if someone wants to participate tomorrow, what do they do?
Yeah, I mean, so we do have the institutional approval. So we received IRB approval. So we are in the clear now as far as being able to start recruiting patients. We're just finalizing the actual clearing of now that we have the IRB approval, getting the final funding put through, but we have already been awarded obviously the grant. So yeah, we are now at the point where we can start recruiting patients and getting them enrolled.
Great. This is exciting.
Mm-hmm. Yeah,
well, anyone with interest in becoming healthier and getting support for that and contributing to our understanding of how lifestyle interventions impact outcomes, hopefully in a positive way in MS, feel free to reach out to Jules and we'll work together. So thank you again.
And if I could just chime in real quickly as well, Dr. Miravalle and Dr. Kaplan, the next multiple sclerosis brain health program, the educational piece of that CLIP-MS study, will be starting May 6th. So we do have one right around the corner that will be starting up. So for folks who are interested and meet the criteria, just wanted to make sure I put that out there. That's, again, the 3-week program. We meet on Tuesdays and Thursdays over that 3-week time frame, and we start May 6th, and then there'll be another one as well in August. And I did fail to say right at the beginning, for anybody that does have questions, and Dr. Miravalle did mention this just briefly, please do go ahead and put your questions into the Q&A box, and I will monitor those throughout this session. So thank you.
And Kathy, I see a couple of questions already coming in. And so is this an outpatient program, and how often are the appointments, Dr. Kaplan?
Yes, so this is an outpatient program, and so so it will consist of the 3-week education course, which that is at home, so that's twice a week so a total of 6 sessions, and then it'll be a total of 5 sessions with Adrian, and those can either be in person or telehealth. So when we go through the actual screening process, we have a whole calendar for patients to observe, but it's essentially every 2 months meeting with Adrian for a 1-hour follow-up visit. But yeah, there's a form. We have a whole calendar that patients can see when they decide to enroll in the program that shows kind of the breakdown of the timeline.
Fantastic. And then there was another question in here that says, can you give 1 or 2 examples of what could be a positive change that occurs to the current program as an outcome of this study?
Yeah, absolutely. That's a great question. So I think that the biggest thing is being able to continue to expand the offerings that we have as a comprehensive MS center to our patients. And obviously we have people here who are really good when it comes to the medication management and the actual reading MRIs and diagnosing and managing MS. And I think the goal is to continue to expand upon the level of care we can provide for patients, and by being able to establish data-driven, evidence-based interventions, even just beyond what we can do with medications. So just to give patients a more holistic, more comprehensive treatment of their multiple sclerosis.
Fantastic. Well, thank you so much, Dr. Kaplan and Jules, for giving us an overview on this exciting project. I'm happy to be a part of it as well. So, Dr. Miravalle, I'm going to turn it back to you, and I think we are going to bring Dr. Shoemaker on here. So I am going to allow for that to happen. Fantastic.
Excellent. Thank you, Kathy. And Dr. Shoemaker, can you hear us?
I can hear you. Can you hear me?
Yes, excellent. Very good. Well, wonderful having you here, and thank you for your participation. And I have a lot of questions for you, and probably we can start with some of the exciting news that were shared in the last American Academy of Neurology meeting, which happened last week. That's the largest international, even though it's national, but becomes an international audience meeting for neurologists in the world. And, I didn't attend, but how many people attended? Do you know?
Tens of thousands. I'm not sure exactly, but there's well over 10,000 people that attend.
Yeah, and for all of us nerds in neurology, it's kind of like our annual reunion, right? You get a little bit of that, camaraderie, networking, but also wonderful updates in research that is happening in MS. What stood up for you?
I would say it's a lot like going back to high school, right? You see a lot of old friends after a summer, but you realize you still don't know as much as you think you know. There's a lot of really exciting updates for MS, and I think probably the biggest updates had to do with lifting the embargo on some of the publications for the BTKI medication, specifically tolebrutinib. And so there's a couple large plenary sessions that reviewed the phase 3 results of the Gemini 1 and 2 studies in relapsing MS, and then the Hercules study in non-relapsing progressive MS. And so I'll probably start off by talking about those if you'd like. Tolebrutinib is of this new class of molecule that's a BTKI, so it's a Bruton's tyrosine kinase inhibitor. And what's interesting is that it's a small molecule that's brain penetrant, and so we think it's unique in that it can actually cross the blood-brain barrier and possibly exert its effects within the brain itself. It also has some unique targets in how it works, and so similar to our currently available medications, it does have some impact on B cells, similar to ocrelizumab or ofatumumab. But it also works on what are called myeloid cells. And most interesting of those would be microglia, which are actually the innate immune cells of the brain. And so the idea being perhaps by directly penetrating the brain, directly having some impact on myeloid cells within the brain, perhaps this could have some unique results. And so the larger of the studies with Gemini 1 and 2 were looking at tolebrutinib, and they compared it to an established medication, teriflunomide, also known as Aubagio. And they looked at the comparison between the two medications and its impact on annualized relapse rate, MRI activity, disability progression, and then safety and side effects. And so these are two very large phase 3 studies. One of them had over 970 patients. One of them had almost 900 patients. So really a large number of patients, and it really kind of helps prove or disprove whether a medication works. And so in the end for the Gemini studies, what we were able to see is that, yes, tolebrutinib does exert some influence on relapsing multiple sclerosis. However, it does not appear to be significantly superior in any way to what's already available with teriflunomide or Aubagio. And so its annualized relapse rates were basically about the same. The MRI outcomes are about the same, if not potentially less effective in terms of MRI outcomes. And safety-wise, it does appear to be quite a safe molecule, with the exception that there's some rare instances of elevated liver enzymes, and so that just requires some monitoring. What's interesting, though, is that in the relapsing MS studies, there does seem to be a little bit more of an impact on disability progression. And that's always something we find that's interesting. However, the study itself wasn't necessarily designed to answer that question. This is a secondary endpoint, so you can only make some inferences, but you really can't draw any firm conclusions. Fortunately, however, the other study that they announced the results for was the Hercules study. And so Hercules study was a unique study in that it was comparing tolebrutinib versus a placebo in non-active progressive or non-relapsing progressive multiple sclerosis, right? And so these are those patients of ours who have had secondary progression, they've continued to progress and are accumulating disability despite being on medications. And so what's interesting in this study is that it did show a benefit in terms of disability progression versus placebo. And so there was about an 8 to 10% reduction in the accumulation of disability over 2 years compared to placebo. And that was found to be statistically significant. So that's really impressive. And so when you combine those results potentially of the Hercules study with the Gemini studies, it does seem to exert some type of influence on non-active, non-relapsing progressive multiple sclerosis. And this is really something that we really haven't seen a lot of. Now, the size of the effect, we'll see eventually once we're utilizing in day-to-day practice, but it does seem to exert some influence on progression. And in some ways, I'm a little bit more convinced that it's accomplishing this goal, just at how underwhelming its results were in the relapsing MS study. Oftentimes, when we've seen some medications, purport to show an influence on, progressive MS, we really think a lot of that benefit's being driven by a small population of really inflammatory MS patients that probably didn't belong in those studies. But that's not what we saw in the inflammatory relapsing MS studies. It really didn't have an influence on that type of MS. And so I think there potentially could be a role for this type of therapy for our progressive MS patients where previously we didn't have options before.
Yeah, that's interesting. And just to bring the audience to speed in what we are discussing here. So the way we kind of conceptualize MS these days is driven by two processes. One is what we call acute inflammation, right? That's the type of inflammation that is responsible for new lesions or those scars that we actually see on the MRI that actually gave the name multiple sclerosis, but also responsible for the relapses or the clinical attacks. So that's acute inflammation. For that, we have many medications, many options available, and some of them are really effective at reducing new lesions or new relapses to the degree of 97% reduction in new lesions. So we do have a lot of options for that type of inflammation. But the second type of inflammation, something we call chronic inflammation, some groups like to call that smoldering inflammation, is that type of inflammation that becomes more compartmentalized in the brain, right? So once these immune cells reach the brain or the central nervous system, they like to stay there. And they continue to cause this slow process of inflammatory responses that is perhaps responsible for more subtle things, right? Things like brain atrophy, or as you mentioned, activation of other type of cells called microglial cells. And as you mentioned before, in order for medications to be able to have an effect in that type of inflammation, there are certain things that have to happen. One is they have to penetrate into the brain. They have to have a good action, not only get into the central nervous system, but has a direct effect on certain cells. And unfortunately, most of the therapies that we have available don't. And to few, some exceptions are there, right? So the oral therapies, for the most part, they tend to have better chances of getting into the CNS, but those large molecules, the ones that we infuse, they don't. So when you look at that and you look at BTK inhibitors like lerubrutinib, so if I understood what you're saying is basically you are more impressed by the effect on that chronic inflammation as opposed to not that impressed on the effect of acute inflammation. Is that correct?
That's exactly what I'm saying is I'm unimpressed by its acute inflammation activity, but as a result, it actually makes me more impressed what it's able to do with that smoldering locked away infusion.
So if you think about this, and if this translates into, let's say, an approval of the medication that becomes available in the next 6 months or so, how do you think of using this in your kind of armamentarium of care for MS patients?
I mean, I think we're going to have to be very smart in patient selection for these types of therapies because, we've both gone back and forth on this and that it probably is not a top line high efficacy medication for that acute inflammatory disease activity. And so patients that we really want to make sure they're not developing new lesions, they're not at risk for relapses, it's probably not going to be the appropriate therapy. However, patients where we know we've done an excellent job at preventing new lesions, we've really tamped down that inflammatory activity, but we have some concerns that they're either having some signs of progression or they're at risk of that progression. those are the patients where it probably will have a role in our practice.
And the question is perhaps the million-dollar question here. How good are we? And when I say we, it's not just us here at Rush, but the MS community in general at measuring the signs of progression. Do we have the tools these days that we can use to say, hey, if an MS patient feels that things are getting worse, how can we reliably measure that in a way that we can inform the use of these type of interventions in the future?
I mean, I think we are both, yes, we have the tools, and no, we don't. Depends on how you approach it. So I think most of the time the patient honestly tells you the truth. We just have to make sure we're asking the right questions. And a lot of that is, how have you been in the last year? How do you compare yourself to 6 months ago, 12 months ago? And sometimes that's it. That plus a good examination can really answer the question for you. But sometimes patients don't always tell us that, and sometimes it's a little bit more nuanced. And that's where we're trying to probably rely on a little bit more of this new data we have. I think a lot of us in our group are now sending some of the serum biomarkers a little bit more, our GFAP, our NFL, that may be helpful. If we're taking more of these patient-reported outcomes, I think that's going to be really high yield in this instance. We have fancy new MRIs now that are giving us brain volume and comparing them and lesion volume. I don't know if that's going to play a role, but they look pretty. So we're getting more and more data, and I think part of it is that we're capturing data. We weren't fully sure whether we could really implement something to change the direction of that. But with this type of therapy, it may be more important to be collecting the right data because we now have the potential to influence it.
Excellent. And you mentioned a blood test. Can you dive a little bit deeper? So can you do a blood test and with that inform if there is progression?
Yeah. So, I mean, I think, we from our center, some of us have been sending off the neurofilament light chain for a little bit of time now. There's a couple of different ways of getting that accomplished. Mayo Clinic had a test, LabCorp had a test, and then the Octave panel also included some neurofilament light chain. And neurofilament light chain is basically a marker of nerve injury. We haven't always, but for a while, you've been able to measure it in the CSF, but only recently have there been these 3rd and 4th generation assays that we can reliably quantifiably measure it in the blood. And that's a marker of nerve injury. More recently, with the Octave assay, and now LabCorp has this combined NFL GFAP test, we've been able to measure this thing called GFAP, which is glial fibrillary acidic protein. And that's a marker of NFL is that neuron health marker, where GFAP is kind of that glial health marker. And so they tell you something similar, but different parts of the central nervous system. And these tend to be pretty sensitive markers of nerve injury, myelin injury. They tend to correspond to prognosis, disability progression, and in some cases, treatment response or non-response. And it's a numerical value that we get that are compared to controls. And so it gives us another way of monitoring the disease state.
Excellent. And so I'm just monitoring some of the questions. And I think the next one is related to your next section, which has to do with cell-based therapies in MS. And there was a recent award, the Crawford Prize Award, given to a researcher in Australia. He's looking at, checkpoint inhibitors and different ways in which these B cells actually throughout the process of becoming, eventually autoreactive B cells or responding to the wrong antigen in the case of MS, how we can actually stop that process through different approaches, particularly cell-based therapies. So what can you tell us about what you learned during AAN in terms of things like CAR-T therapies or even stem cells?
Yeah, so I think probably what was getting a lot of attention at the time was the CAR-T therapies. And so CAR-T basically stands for chimeric antigen receptor T cell therapy. And the idea is basically using your own T cells and you're reprogramming them against a specific molecular target and using a cell to basically accomplish the ends. And so we have similar therapies in the idea that our B cell therapies are very specific in its molecular target. We're targeting CD20 or sometimes CD19, and we're using an antibody to accomplish that. With the CAR-T therapy, the ones that they presented results from we're specifically looking at CD19. So CD19 is kind of along that maturation pathway of our CD20 B cells, but it happens a little bit earlier in the pathway and a little bit later. And so the idea by targeting it, you may get a little bit more robust depletion of those cells, and you may get a little bit broader influence. The idea is that potentially using these types of therapies, it could be a reprogramming type of treatment. And the benefit of using a cellular-based rather than an antibody-based therapy is, again, you may be able to get into different compartments of the body than you may have been able to previously with just an antibody-directed therapy, and it may recruit different types of responses. Now, they only presented the results of a small number of patients, just a handful, and these are really early phase studies. They were looking predominantly at safety outcomes. And why that's important is we know predominantly about CAR T and its utilization in malignancies and cancers. And there can be some pretty significant side effects and safety events. Often they can get these really big cytokine storms or these total body inflammation storms that can really progress, and it can even lead to like brain swelling, to give you an example. And so that's when I first heard that we were doing this to our MS patients. I said, "Oh no, I don't." I was worried what it would do to our patients. But the nice thing was that they basically showed that the results were extraordinarily safe, relatively speaking. Of the patients they presented, there was really only one small immune complication, which was a rash. And what they had postulated is basically when you're treating a malignancy, you're really going after very highly cellular targets, and you're going to be lysing a lot of cells. You're going to have a lot of consequences of that. Where the targets in MS, while cellular, are not quite the numbers to really have lysis to drive a systemic inflammatory response. And so it looked a little bit different than I was expecting. These were very small numbers of patients. You really cannot make any inferences about treatment outcomes or benefits or efficacy. But of what they presented, it looked like it maybe had a potentially positive benefit. Right. And these were in advanced cases of MS too.
Excellent. No, and the exciting thing is if you look at the history of therapies in MS, right? So we started with purely anti-B cell therapies, and that began with the good old rituximab, a pivotal moment in MS therapeutics in which we truly understood that B cells play a critical role. And if you eliminate those circulating B cells, the ones that are like going into the blood flow, you can have a profound impact in acute inflammation. And now we are becoming a little bit more nuanced, right? I will say with things like Mavenclad, we are learning that with an oral therapy that transiently affects B cells and actually penetrates the CNS, you can also have a profound effect that is long-lasting, particularly if you go after a subtype of cells called the memory B cells. Now, what you mentioned before with tolebrutinib, a BTK inhibitors, you're also going after B cells, but also other type of cells in the CNS with microglial cells. And now with CAR T, not only we go after B cells that are circulating, but may be able to go after the ones in the lymph nodes, in the brain, in the spleen, in organs that perhaps with these antibodies, they cannot get into those organs and truly affect those cells. So we are becoming a little bit more nuanced, more specific in our way to actually address a cell that is causing a lot of trouble in our MS patients. Would you say that that is accurate?
So what I would say that supports what you're saying is one of the cool findings that one of the groups showed was that when patients were treated and they followed up in the spinal fluid, they saw a disappearance of the oligoclonal bands in the CSF. Right. And the idea is perhaps that some of the memory B cells and plasma cells that are in those meningeal follicles that are within the CSF that drives this compartmentalized inflammation, perhaps you're having an influence on these and causing them to basically to go away, and that's going to have a significant impact on the CSF resident inflammation.
Let me highlight that a little bit more in detail for our audience. So what Dr. Shoemaker just explained, I think is critical, which is, if you had a spinal tap at some point in your diagnostic, process, the reason why your doctor ordered a spinal tap is to look for a marker of inflammation that we call oligoclonal bands. So we know that those bands are proteins that are secreted inside the central nervous system. And under normal circumstances, you shouldn't have that. So the presence of those bands is telling us that there is inflammation that is happening, that is coming from the inside of the brain. So with our therapies currently, even though we achieve great clinical benefits, we cannot eliminate those bands. Those bands remain steady and remain positive throughout a patient's life. And we don't know what to do with that. We usually don't think much about it because it's something that we never saw a disappearance of these bands with the therapies that we currently have. However, with these CAR T therapies, the ones that the cells are getting into the brain and addressing those B cells in the brain, you can eliminate those bands. So we yet don't know what that means. We don't know if that's going to translate into better clinical outcomes, whether that's going to translate into stopping the process of MS, but it's highly exciting to know that there is a marker here that might tell us that there is more of a deeper dive into the pathology of MS. Excellent.
I would also follow up and just say, like, the idea being too is this is going to change potentially treatment paradigms, and the idea that perhaps this is going to be a reprogramming treatment that is a one-time thing too. Perhaps this isn't going to be a continuous type of therapy for patients.
Excellent. Very good. And last thing, there's always a question about stem cells. Are we ready to implement that clinically? Question for you, Dr. Shoemaker. Can we use stem cells currently in our patients at Rush?
Yeah, so we have a cell therapy group at Rush that has experience using hematopoietic stem cell transplants for our MS patients. To this kind of, I'm going to sound like I'm repeating myself, but it's very specific in terms of patient selection and who we think these are appropriate for, but also who they're able to treat. There's a lot of obstacles in the way of treating them. And so it does boil down to like a lot of patient selection, but for us and for me, I've had a couple patients who've been successful. They've gone through the transplants, and I would say the appropriate patients tend to be ones who have failed multiple kind of high efficacy treatments one way or the other, though that's kind of a prerequisite for us and for them as well too. And then they have to be able to kind of commit to the treatment paradigm. It requires an inpatient stay. It requires a pre-treatment harvesting of your bone marrow stem cells, and then basically a round of chemotherapy to ablate your current immune system, and then they basically repopulate it with these new stem cells. And so there's, it's a significant undertaking, but I would say that we have successfully worked with our cell therapy partners at Rush for a handful of patients. We've screened even more, but there's been a couple obstacles that have come up. Mainly insurance have been difficult. Of the patients I've seen on the other end, though, a lot of them have had a very favorable experience, and they've done well with the process. I think this is a type of treatment that has had different iterations well over a decade, and so there has been some advancements in the type of protocols used. And it seems one of the main benefits has been safety. So I think that it appears to be a little bit safer regimen than in the past. And so, for the right and appropriate patients, that is one of the tools we have at our disposal now.
Excellent. Very good. Kathy, any questions that came in the Q&A?
Well, I think there's a question regarding the one study from the AAN that Dr. Shoemaker was talking about that highlighted, being a blood-brain, passing the blood-brain barrier. And so the question was, well, there's a lot of talk about MS, patients that might have MS in the brain and lesions in the brain, but what about MS patients that have lesions in the spinal cord?
Sure. Yeah, no, I think that's a really good question. So the idea being that it's probably going to the blood-brain barrier is also the blood-spine barrier, and so it should also be spine penetrant as well too. So these small molecules are small enough that they can pretty much get anywhere and exert their influence. And microglia are throughout the central nervous system.
Fantastic. And should the patients ultimately, when they're coming for a clinical visit, should they be asking about particular tests that should be done?
They can inquire about particular tests. Obviously, it's going to be up to them and their specific physician what tests they're ordering and what what they're using them for. Regarding the serum biomarkers that we're using, these are pretty new, and so we're still kind of figuring out the best ways to implement them and what frequency we're going to be checking them and how we're going to respond to them. They've been helpful in a few cases for me. A lot of times now they're just telling me what I already know, is that the patient's doing really well and responding well to therapy. But at least in those instances, I've got a baseline number to compare it to in the future.
Fantastic. And there is a question particular about Octave tests. So what is the difference between Octave tests and other tests you mentioned? What are they called? And what do we ask for? How often do we get them?
Got it. So I'll start with the last one. How often do we get them? Don't know. Still figuring that out. From there, I'll describe the test. So the most basic one was the first one we had, which is basically just a serum neurofilament light chain, or NFL, like the Chicago Bears. That's the marker of nerve injury. You can get that through, we send it out to the Mayo Clinic. We can send it out to LabCorp. You can go to LabCorp, and that's also part of the Octave panel. Then there's GFAP. GFAP is glial fibrillary acidic protein. That's a marker of glial injury. We can get that through a combined test that we send out to the LabCorp along with NFL. So that's the one a lot of us are probably sending the most. So it combines NFL, GFAP together, and you get two numerical values. And that one is also part of the Octave panel. Octave panel also has a couple different biomarkers that particularly are looking at not just nerve injury, but potential neural inflammation and other types of like cytokines and markers of inflammation. They then have their own proprietary calculation that produces a numerical score that gives you a predicted risk of MRI changes in the next year, basically. The Octave test is a specific branded test. The primary downside to that is it's not always covered by insurance, and actually getting it acquired requires often travel to a specific lab in the northern suburbs.
Excellent. Well, that's all with the questions. Fantastic overview, Dr. Shoemaker. Thank you very much.
You're welcome.
And just for everyone in the audience, we might be going over just a little bit in time this evening, but we have such really good information to share, and I think it's worth going a little bit longer. So just wanted to make sure I mentioned that beforehand. So Dr. Miravalle, I think our next specialist that we have from our MS group there at Rush is Dr. Osen, and so we'll want to make sure we bring her on as well.
Excellent. Thank you, Kathy. And perfect segue, because in case there were questions about, is Rush going to do research in CAR-T? The answer is yes, we are working on it. And Dr. Osen will be the principal investigator for a study that hopefully will be open and ready to go soon. I can't tell you more details about it because there's some steps that we have to go through, but we are hoping to be able to offer a research on CAR-T therapy in our patients very soon. So back, Dr. Osen, you're here to talk us about something different.
Right. Yeah. Can you hear me okay?
Yes, we can.
Okay, wonderful. Good evening, everybody. So we just got approved for a phase 3B clinical trial looking at patients 40 years or older that have been stable on Ocrevus or ocrelizumab, potentially transitioning to a medication called remibrutinib. And remibrutinib actually has the same mechanism of action as tolebrutinib, which Dr. Shoemaker was talking about. So it penetrates the CNS, goes after the microglia, which we think is involved in the progressive type of inflammation. And so this trial is really trying to get at, kind of like was already said, obviously in the beginning of the course when you're first diagnosed, that active, very relapsing type of inflammation, we know we need to hit it hard with a high effective medication like Ocrevus. But the question over time is that acute relapsing inflammation starts to transition to potentially the progressive type of pathology. When exactly do we make that switch? And so this trial, we're looking at patients, again, that are stable. It's relapsing patients, although a secondary endpoint will be confirmed disability progression. But just showing that, again, just to make sure that when you get to a certain point that these BTK medications can hold the relapsing form of MS, maybe around the 40s. So we are about to start recruiting, hopefully get about a handful of patients. But of course, if anybody's interested, we'd be happy to talk in more detail, or if you have any questions now.
Excellent. So if I understood correctly, Dr. Olsen, will be patients stable on current ocrelizumab therapy that are interested in switching to remibrutinib, which is a similar compound to the one that Dr. Shoemaker just mentioned, tolebrutinib,
Right.
with some slight differences, but the same concept. And the idea will be to see if we can add any benefit to the already clinical stability accomplished by ocrelizumab. Is that
Right.
correct?
Want to make sure the relapsing, so no relapses or new lesions if with the switch to remibrutinib.
Excellent. And if patients are interested to participate in that, what should they do?
Let your providers know, and they should let me know. And then we have an excellent research coordinator that we can reach out and give you more information about it.
Excellent. And I heard that you're going to be one of our guest speakers for the May Conversations on Brain Health. Exactly. What is the topic that you're going to be discussing then?
Hormone replacement and how it affects MS.
Love it. So hormones and multiple sclerosis. So if the audience is interested in learning more about it, and not only we'll talk about female hormones, but also male hormones. So stay tuned, and I'm sure Kathy's going to announce that at the end. So I just did a little spoiler alert here. But excellent. Well, thank you, Dr. Olsen. And I saw some questions that weren't addressed by Dr. Shoemaker. Is he still around? Yes, Tom, I see you there. I see a question about Octave and GFAP. So the question is that the best test to do the Octave, or should we just do individual? And then what is the name? So that will be Octave. So I think you already answered. Sorry for bringing you up, but anything else you want to add?
I would say there's no best test. I think us as neurologists probably are most familiar with using the NFL and the GFAP. And so that's more than adequate. That's giving us a lot of information that we weren't getting years ago. And so the Octave gives a little bit more information. And some patients just really want to have every little piece of data that they can get. And so in those instances, it can be helpful. I've had patients get it simply because it could help them make treatment decisions. And they wanted to get every piece of information. But in my clinical practice, I'm predominantly sending the MS monitoring profile from our lab, which includes GFAP and NFL.
And patients can have it here, right at Rush. They can have the blood test done at Rush. They don't have to go elsewhere. And I agree with you. I switched to doing that just simply because it's logistically easier. Nothing wrong with Octave. I think it's a wonderful tool. If patients can actually have the access to go to the lab outside of Rush, that's a wonderful test to do. But I find it easier to do the GFAP NFL at Rush, so patients don't have to travel elsewhere. So thank you. And answering another question, yes, the next Conversations on Brain Health will be the second Monday in May. Kathy's going to provide more details at the end. Anyone can participate. As usual, we record these sessions, and they will be made available for anyone to watch them later, in case you missed that, in our YouTube channel. So with that, I'm going to pass it on back to Kathy.
Well, fantastic. I think at this point, we will bring Ren Dalfors on, who will be from National MS Society. And we are good on time. I'm actually super pleased that we might actually be able to end as planned. So Ren will be providing us an overview of the upcoming Walk MS event, as well as a Bike MS event there in Illinois. Both of those events are Rush-sponsored events, and we will be out there present. We will have some of our folks from the MS division at both of those events. So to give you a little bit of details, if you are interested in participating and joining maybe our Rush team, Ren is going to give you a little bit of detail as to how that would work. So Ren, I'm going to turn this on over to you.
Thank you. Can you guys see the screen being shared?
Yes.
Okay, I'm going to minimize everybody Thank you guys so much, and thank you for the invitation to join you all. As everyone mentioned, I am Ren. I am the development manager for Walk MS at the National MS Society, located here in downtown Chicago. And so just a quick little presentation on a few things that Rush is involved in, and just a very, very high level of some National MS Society resources. Please know there is much more to be found on our website through myself, through Dr. Miravale, etc. So, can I not? Hang on. I don't know that I can go to the next slide. Oh, here we go. Okay. Okay, so just a quick vision on our mission and vision for the MS Society. We are very focused on creating a world free of MS. We are very proud to share that our mission is that we will cure MS while empowering people affected by MS to live their best lives. That is a fresh mission in the last 5 or 6 years, with the word cure included, because we do see one somewhat close in sight. No time frame, so sorry, but we are getting close. And just some details a little bit more about the MS Society. So we were founded in 1946, and we have raised over $1 billion in research in those years, setting standards for diagnosis, symptom management, and clinical trial strategies. We are a resource for over the about 1 million people living with MS in the United States. And we have a lot of participants across several hundred events across the country every year. And I am here to kind of highlight a few of them local, somewhat local to the Chicago and Chicagoland region. If you are happening to join us from outside of Chicago or Chicagoland, the QR codes will still take you to a main spot. We'd love to have you involved in what might be convenient for you. One of the high level things I wanted to mention for the Society is our MS Navigator program. This QR code will take you directly to the webpage with contact information, resources, and kind of your starting ground. But the MS Navigators are highly skilled, compassionate professionals who help connect you to various information. We understand you may be getting some of these from the fabulous team at Rush and your doctors and your neurologists and their team. But a lot of things happen, right? Changes in diagnoses, changes in insurance, maybe changes in disability and maybe needing home modifications. Changing things in what's maybe going on at the federal and state level. And these wonderful individuals are here to kind of help navigate that for you. Again, once you kind of get home and you're processing everything, and they are available Monday through Friday, and for anything. You could have been living with MS for 2 decades, or you could have been diagnosed yesterday. So just really excited to kind of provide those resources to everyone. We also have lovely support groups across the country. This again will take you directly to the website with more information. We have hundreds of support groups across the country, including virtual and in-person options. Some have both. And guess what? If you decide to join one in Chicago, but you want to attend a virtual one in Michigan, go for it. I'm sure they'd love to see you. And great opportunity to kind of build that community and meet others living with MS, support us, caregivers, etc. And then our MS Ambassador program. It's a network of passionate volunteers representing the MS Society. You do go through a little bit of training with this. It is free, but for those who might be highly involved in their community, a support group leader, wanting to attend, festivals and events on behalf of the MS Society, sharing some of those resources, getting involved again in their community. That's a great program to kind of look into and explore. It's a growing program we're very proud of. I will not be the one to speak the most on MS in terms of who's in this room today, but sharing some of where we are focusing our research time, resources, funds raised for what we're calling our pathways to MS cures. So stopping MS in its tracks, restoring lost function, and ending MS forever. So this is the pathway we are desperately focusing on for, and how we are making those very large financial research partnership decisions throughout the year, kind of falling into these categories and really focusing on no disease progression, regain lost function, and no new diagnoses. So this is a very fresh in the last couple years. Details, again, a little bit more of a chart on what we do at the MS Society, improving access to personalized, affordable healthcare, empowering people affected by MS to solve challenges every day. Those MS navigators, right? They're wonderful at that. Strengthening the MS movement through more and deeper connections, maybe a support group or an MS ambassador program. And accelerating cures through global leadership. Again, how we are deciding where a lot of our financial and resource backing is going. We will cure MS while empowering people affected by MS to live their best lives. Again, just a little screenshot. I'm not going to read all of this. And I think we're going to allow everyone to hopefully have this deck. Well, it'll be in the presentation, I suppose, since we're recording, but have access to this in case you want to kind of read through things. But just a little bit more about what our impact is on a, national and global level at the MS Society. So we partner with, tens of thousands of healthcare providers like Dr. Miravalle and his team and the team at Rush, and again, that 1.1 billion in research. We've got MS activists on the state and federal level. So that's another opportunity to get involved if that's of interest. We've got some really wonderful resources there. And we've got we've got dozens of types of events and hundreds of events across the country to participate in. Again, I'm kind of highlighting a few of those. And here's the big team that I'm a part of, and the big partnership that Dr. Miravalle and team is a part of, Walk MS. So what is Walk MS? Walk MS is one of the largest nonprofit walk series in the US. We will be over at Soldier Field in 2 weeks on Sunday, April 27th. And Walk MS is a community of passionate individuals to connect and raise funds to change the world for everyone affected by MS. It is the largest gathering in the MS movement across the country. We are very proud to bring these resources, connections, and a wonderful day of community and connection to our local communities. And we'll hop into very specifics. So first, there's a few more events, but first and foremost, our Walk MS Chicago event will be Sunday, April 27th. We're over at Soldier Field in the South Lot. And Team Rush is very involved. That is how I am generously here today. So you guys as a team are a sponsor. You will have a part of our top fundraiser area, as well as a tent that Dr. Miravalle and his team will be a part of. We are very, very excited to host you all. And so there's a little bit of event details here. This QR code is going to directly direct you to the team. We would love for anyone to join the team. Kids included, do not have to live with MS, caregivers, doctors, patients, whomever. This is a family-friendly, dog-friendly, fabulous, fun Sunday, hopefully sunny day over at Soldier Field. So site opens at 9:30. We do have a lovely ceremony on stage that starts at 11:15 with our circles of support. I will be actually on stage with our honoree, who I have a great relationship with, who happens to live with MS. And then we will do a little walk. You have a 1 mile and a 3 mile accessible option. It is free to register. Fundraising is highly encouraged. And registration's very easy. So you don't have to, you can make a decision on what route you're going to take that day. There's no separate registration. And again, we would just love to see you guys. And you can walk around. You could, meet and greet Dr. Miravale, ask some questions, take some photos. We've got other partnerships with, many other, local hospitals and resources, University of Chicago Medicine, Northwestern is the presenting sponsor, Option Care Health, a new infusion center that's gone national, and a national partnership we're very proud of. So it's going to be a very big party. So that is the primary excitement here. But if that date or that location does not work for you, we would love to see you at any one of our other 7 events in Illinois. So this QR code is going to take you directly to the Walk MS page. You will have to sort for what event is convenient for you. I personally will be at the Chicago, Itasca, St. Charles, Peoria, and Libertyville walks, if you really want to see my smiling face. But one of my teammates will be at all of the other events. And as you can see, we've got some great locations, several different weekends. You could come out to more. You could start your own team. Fundraising is available and highly encouraged through end of September. So if you've got some great ideas, some fun engagement with your, friends over the summer, I am going to be a resource for that. Think of everything from matching gifts to, I know we just finished basketball and football, but football squares or March Madness bracket, and you do like a 50-50 raffle, just a generous contribution, if you have so. So we've got some great resources. Again, if you happen to be also checking in from a different state, we have walks in every state. Some states, especially larger states, right? We've got for example, California, right? They've got one, in LA, San Francisco, closest to Santa Barbara, San Diego, Orange County.
So Ren, I think we are running out of time. So
yeah.
I need to stop here, but thank you for your contributions. Thank you for helping us. I know we have Bike MS, but we have no time to go over that. But it's a pleasure having you, here. We are excited to be part of this wonderful event. Kathy, I'm going to pass it on back to you. I want to be mindful of people's time.
Well, Ren, I feel like you need to catch your breath because you really speeded through that. Thank you for being sensitive to our time. I want to say a huge thank you, first of all, Ren, for presenting information from the National MS Society, but of course, to also say a huge thank you to our MS doctors at Rush who gave us a lovely overview on some of the research updates that are happening. For everyone, our next conversations on brain health in May will be on May 12th. So again, it's always going to be the second Monday of every month. And as Dr. Augusto Miravale mentioned earlier, it will be talking about the impact on hormones, so impact of hormones on and on your symptoms for MS. So apologies. So we will have Dr. Allison Osen as well as Dr. Billy Conti, who will be presenting for our next session. So hope everyone will be able to join us, and thank you so very much for being with us this evening. Happy spring, everyone, and look forward to having you back with us in May. Dr. Miravale, anything else from your side?
No, I would like to thank all the speakers, Dr. Tyler Kaplan, Dr. Tom Shoemaker, Dr. Ali Olsen, Jules Skoda, and of course, Ren for being here today. That was a wonderful session. It's exciting to see all the wonderful things happening in research, and we'll see you back in May.
Yes, absolutely. And anybody who is interested in the presentation from Ren, I am more than glad to share that. So always feel free to reach out to me if there's any additional questions as well. Thanks so much and have a wonderful evening. Take care, everyone.